Breast implant removal or explant surgery is a procedure that I perform more and more commonly in my practice in Miami, Florida. Making the decision to remove breast implants is not an easy one, and sometimes understanding the mechanics of what goes on and what's involved with the breast once the breast implant is removed helps the patient make the appropriate decision with surgical planning. Now let's go to the chalkboard and take a look at some diagrams to better understand the problem of breast implant removal. Now, occasionally I'll see patients, they're young and they've had multiple operations and they've tried doing capsule reconstruction, they've tried the meshes, they've tried the collagens from the cadavers, and it hasn't worked, and ultimately they're frustrated, or the pocket's been over dissected. They have synmastia where the two breast implants touch, they're bottoming out very low onto their abdomen, they've tried multiple operations. For patients who've tried multiple operations and ultimately decide they want to remove the implants, this we make sometimes as a permanent decision that we want to remove the breast implants and never replace them. And other times, like on this patient who had a breast infection after breastfeeding and had to have her implant removed, we gave her an implant break, allowed things to heal, and then came back and placed new breast implants. But coming back to the drawing board here, the problem with removing the breast implant, as we see in this diagram, is there's a pocket that wants to collapse. And depending on the size of that breast implant, that pocket could be huge in proportion to the breast tissue. So a large collapse of this pocket can lead to problems where the implant, if it's placed in the correct position, both of these are not the correct position, right? The correct position of the implant is that it is centralized under the nipple areolar complex, okay? If the nipple's really low, then we want to lift it up because we have to put the implant, again, between the breast fold and the upper portion of the breast, okay? But again, the goal of the implant, where it should be placed, the proper anatomic location, is whether you're above the muscle or below, the proper anatomic location of the implant is the apex of the implant is at the level of the nipple areolar complex. So what that means is the nipple areolar complex is the tip of the mountain. It's basically where there's maximum projection of the implant. People talk about implant projection. They talk about high profile, low profile. What does that mean? It means the amount of projection that the implant has, and that can be 4 centimeters or more. So if we're looking at a larger implant that has a lot of projection, okay, and that implant gets removed because the patient has had a hard time with implants, has pain, has given up, or we're taking a temporary break, the patient really has to know the sequela of removing that implant because this pocket wants to collapse. And when this pocket collapses, things can happen that don't look so good. Specifically, the big thing we worry about is nipple inversion. Okay, so the nipple, which is the tip of the mountain, wants to collapse and come down to the chest wall. And when it does, the nipple can actually become inverted or almost like a innie belly button. Additionally, the skin below, where it's the thinnest, can be ripply and wavy and cause some irregularities or indentations down to the chest wall. If we go back to our dual plane, above the muscle, below the muscle that we talked about earlier, even if the implant is below the muscle and this patient decides they want their implant removed, okay, temporary or permanent, we could take this muscle and we could try to pull it down below the nipple areolar complex to add some bulk to help decrease that pocket collapse. But this muscle typically isn't that thick and it doesn't give us much to try to avoid this problem. So what can we do when we get to this problem? Well, I'll tell you, sometimes this is a safe spot to go to when you're having recurrent problems like this. This is very hard to fix. This is very hard to fix. If we take all the capsule out, we remove everything, we allow the patient to heal, we can always come back later and do an implant or do another operation, okay? So some patients that have had 6 operations before they're 30, this is something to consider either as a temporary or permanent solution. But if patients do not want breast implants again, and they want their implants removed, in order to avoid this situation, there's a few things we could do. So when patients have their implants removed and we have problems with a large implant and collapse of the nipple and wavy irregular skin because the skin has been stretched out, One option is to harvest fat from areas they don't want, like the love handle or abdomen or inner thigh, and to try to come in and place some fat grafting underneath the nipple, and sometimes we'll put it into the muscle too, and then that'll help try to push out that area and shape the breast better. And we could also put some up here on the upper pole to give a more round appearance. The difficulty with fat grafting is we still can't get all the fat to survive, and it's variable depending on the patients. Patients who are healthy and don't smoke tend to have higher fat survival, obviously, but still, even in healthy patients, we estimate 40 to 60% of fat survives. Some of the fat lives, it develops a blood supply and stays with the patient forever. Some of it becomes absorbed by the body, it doesn't develop a blood supply, it dies and it gets absorbed. So, we have to judiciously put the fat in, and we have to put it in like this, in little spots, and we want to plant it like little seeds being planted into the soil. We don't want to pour all the fat into this big pocket, because the only place that fat filling this big pocket would get blood supply is on the perimeter edge. All the fat in the middle, which would have no blood supply, would die. It's kind of like planting apple seeds. If you want all the apple seeds to live, you have to plant them and spread them out so they're each surrounded by a lot of soil. If you dig one hole and dump all your apple seeds in that one hole, none of the apple seeds are going to grow. So the same thing is with fat. The other thing with fat grafting is you can't pour a ton of fat into the breast. You can't inject a ton of fat into the breast. There are limitations. If you try to inject too much fat into the breast, the pressure from the heavy injection can actually kill the fat cells. And a lot of dead fat cells can lead to infection. It can lead to lumps or bumps that can cause problems with imaging and lead to breast biopsy in the future. The other thing that we've looked at is studies have shown about 6% of patients that get fat grafting to the breast do have something on breast imaging that could require biopsy. And this is very similar to breast reduction surgery as far as the numbers of findings on imaging. So what else can we do besides fat grafting to try to correct this problem? Well, the other thing, and we'll talk a little bit more about it later, is a breast lift. So we can take that skin and we can tailor it and we can shape that stretched out skin to give the patient a better shape. So if a patient doesn't want implants anymore and removes the implants and has the problem with this pocket collapse, which we almost always expect with a larger implant, we can add fat to try to push the nipple back out, or we could do a breast lift, which we'll talk a little bit more about later. And what that breast lift does, it allows us to tailor and tighten that skin and put some tissue underneath the nipple to get projection. The most powerful procedure when you're removing an implant and not replacing it to shape the breast is a breast lift. A second tool that really helps us is fat grafting, and we combine the two as we have in this patient, which I'll show you. You can see that we were able to get a better shaped breast even though she had relatively large implants. And there's often a benefit of where we harvest the fat from in order to give the patient the best aesthetic result. Now, when a patient already has a breast lift, it's a much easier decision to make because they already have the scars associated. And the scars of a breast lift are forever. So if a patient decides she wants to put her breast implants back in, such as this patient, we took her breast implants out because she had an infection. She always wanted to have breast implants again. She was having a lot of recurrent problems. So we took the implant out, gave her some time off, allowed her to cure the infection, and came back and replaced the implant. And you can see we've corrected the wavy irregular skin on the lower pole and the nipple inversion. She did have a scar around the areola to decrease the areola size. Again, the donut mastopexy, or the scar around the areola, I think it does best to really just lift minimally and more reduce the areola size and shape it than it does to actually perform a breast lift. Deciding to remove your breast implants or have explant surgery is not an easy decision. Every patient is different. The size of your implants and the amount of breast tissue that you have makes a big difference in what's the right operation for you. See a board-certified plastic surgeon experienced with breast explant surgery and subsequent breast reconstruction to figure out which decision is the right one to make.